Our next presentation is entitled Digital Implant Dentistry, New Technology for Teeth and Implants. Our presenter is Dr. Frank Higginbottom.
I'm right here.
There you are. Please welcome Dr. Higginbottom.
Thank you so much. Appreciate that. Okay. I'd like to make a little correction. I may have given them wrong information, but I was actually past president of the American Academy of Restorative Dentistry. I am a member of the Aesthetic Academy, but I was not president. So I'm going to share with you some stuff that I do in Dallas. And thank you, Jay, again, for a great presentation, and Dr. Gallucci. And I told Erman that I was probably his opening act, because this afternoon at 1:30, he's going to present all on digital impressions, which I'm going to touch on. So the things that are interesting to us today are the fact that we have other things that we can do, okay? We all have conflicts of interest or things that we need to tell you that we are involved in. I certainly have been involved with Straumann, the ITI Foundation, for grants for doing some research, and various other people like Brasseler, Dentsply, DECA, and Straumann. And I'm an investor in an imaging center, actually probably have 10 imaging centers in Texas and Tennessee, et cetera, called ImageDent. So I would say that most of these technologies, you can have all of them in your office, but it might be, particularly from a cone beam standpoint, with the expense involved, and the fact we don't use them on every patient, is that you just need to have access. So that is what you need. So I don't own one myself. So when we look at the things that I'm going to talk about, we look at digital records, which we've all done for some time. We have progress notes that we kept, which makes it a lot more easy. Digital radiographs, and I dare say that the great percentage of you in the room probably don't do digital radiology. My best friend still does analog films, okay? CAD-CAM restorations, guided surgeries, and of course, digital impressions. I think the one thing in the digital workflow that really has tied this all together and is a key point would be the digital impressions. So in digital dentistry, we talk about our records, progress notes, and digital radiographs. So this has made radiology a lot more transportational. In other words, we don't have to put something in an envelope and put a stamp on it and mail it. And then with the cone beam CT, we've learned that we can find out a whole lot of stuff that we didn't know before, okay? And that's a nice thing. And we've practiced so well for so long with very little information, okay? We can continue doing that. So you've got to ask the question, do I need all these technologies to continue doing good work? And the answer is no, okay? So when you look at what we have in the way of accuracy, cone beam CTs, if we do cuts every 0.5 millimeters, and we look at them, research has shown that they can be accurate up to, is inaccurate is up to 0.2 millimeters. So that's really pretty good. And I would say that most of these others, done correctly, give you good information. So ask a question. So our residents placed 5 implants with a very little AP spread, and then we got an ICAT at the dental school. And I'd ask this question: can technology prevent problems? Okay? We can use it to gather information and use correctly, but if you look at the plane of this healing abutments there and think, where are the apices of the implants going to end up? Okay? So does this technology keep you out of trouble? Well, let's just look at this, because we're going to place some additional implants, and we look at the first one is there, the second one, the third one, the fourth one, and where is that one? Okay? So it'd be nice if you could put your finger on the lingual there, and if something starts touching it, what is that? Maybe I should stop, or do you speed up and press harder with the drill? At what point did the drilling get easier? Okay? So, can technology prevent problems? No, not without good judgment. So, technology will not overrule stupidity. Okay? So, I can go home and do the same things I did 20 years ago and do them pretty well. I think I have some things that help me do it a little bit better, and then we're going to end with some of those questions, okay? So, I can use a guidance program, and it requires me to have a cone beam CT, and I can place my implants digitally, okay, with any system, and I can learn where the mandibular nerve is, and I can learn that there are undercuts, okay? And before, just visualizing a two-dimensional film or looking at a cast or looking at the patient, we didn't know that there's an undercut here and the nerve was down there and there's a lot of available bone, but we might end up in the floor of the mouth, okay? So you can make corrections without actually doing guidance surgery. And we learned also that the mental foramen wasn't where we always figured it was, and it exits in a superior position. And we know that in the second premolar position that we don't place long implants anymore with the information, and we don't have that $250,000 misunderstanding. Okay, so a lot of these things, you know, I don't have to take responsibility for because I have a surgeon like Jay and Tom Wilson and people that do that look at the cone beam CT, and we know when we need one. Posterior mandible would be a good one to consider, okay? And then CAD-CAM restorations, okay? So we've all known about CERAC, Sirona, and stuff like that. And there are times when you can take an image of your preparation and you can mill out after you design a restoration. So there's a place for that, okay? So that started that way. Then we got to the point where we'd either send an impression or a scan or a cast to our technician. They'd put it in a desktop scanner and in there the digital world, okay? So we could still take an impression, send it to our laboratory. They'd either scan it or pour it and then scan the model. Or what if you could, at the time that you started a procedure in the operatory with an implant or a tooth, if you could just scan it, and now you've got an STL file that's transportable to any place in the world almost instantaneously, okay? And then you design something, and then you can have it milled out at a centralized milling facility that's very accurate, and then you see that you can mill out just about any material in any of these centers. And there are numbers, Straumann, 3M, Nobel, all of them do something like that. And of all these different materials, you can have a monolithic crown milled out. You can have zirconia copings and frameworks, titanium screw retain frames, methacrylate frames. And then, of course, the biggest thing for me is being able to design my own custom abutments that actually match that implant system that I'm using. So you've got titanium and zirconia. So pretty much everything I do is a custom abutment that can control the cement line, and you don't get into some of those problems because most of the restorations I do are cement retained. So guided surgeries, okay? So we know that we can take some plan program like Jay showed us. This happens to be anatomage, and this would be some guides that were generated from Simplant. And any of those are going to start with some sort of a cone beam CT. And then the cone beam, luckily, in radiology, we have something that's uniform. So the standard in medicine and dentistry is this DICOM file, which is digital imaging and communication in medicine. So I can take a cone beam CT and I can send it to anybody and they can accept it and import it into a program. Now, what's going to be interesting with digital impressions is there's stuff in the works today to actually have a common language. And essentially, this is going to be an STL file. Now, all of the things that I'm going to show you are something akin to that, but they have a little code on them that maybe they're not completely acceptable by all the different software packages, okay? But essentially, that's what they are, okay? So we can import a DICOM file into Simplant, or with Astra and 3i, they've been licensed by Simplant to have the same software. Easy Guide is actually anatomage. Nobel Guide is proprietary. Co-Diagnostics is the Straumann version that Jay started showing you. Okay? So any of these are going to give you something, and if you have the information, you can do things flaplessly, and it's marvelous, you know? You don't have to worry about handling soft tissue. And if you have the information, you can do these things, and patients are happy with you. The disadvantage to not laying a flap is you don't have the opportunity to augment at the same time. Okay, so very selected cases are things where you can use that technology. You can also look that There's not a lot of restriction when you go into this implant guide, is you can change the direction quite a bit, and by the time you get to the apex, you could be 15 degrees off. Okay, so the guidance system that Jay showed and Herman showed is something that we use today. Okay, so let's take a case like that. Now, I chose this one because it's easy to photograph. Now, I could do this with any technology or without any. Okay, so we've got a lady that's 47. She hasn't had her central incisor since she's 7 years old. She's raised 3 children wearing a flipper. Okay, so what's happened? Okay, obviously these teeth, the 7 and 10, probably have an apex that's up here in our way, and obviously there's not much bone left, and the lower incisors have erupted into the site. So it's in my restorative space. Okay, so how many of you would just say, well, I can just stick a couple implants in, or maybe even still, because knowing from my community of people that are looking at what can I get done easiest, why don't you just crown 7 and 10 and make a 4-unit bridge? Okay, luckily that's not our intent. Now, what we can do is change the site just a bit by getting the teeth out of the way, by getting the lower incisors out of the way, and then by augmenting this and making some bone. Okay? So we have other technologies that allow us to do this. So Tom Wilson and Terry Adams did this. They did a graft. Same time, they did the surgically assisted osteogenic orthodontics or wilcodontics. Okay? And we know that if we injure the bone, we can change the metabolism and move teeth a little quicker. We also can add bone where you don't have it over the roots of the teeth. And you can take this picture here and actually improve it. So we're going to do graft, ortho, and the surgically assisted osteogenic orthodontics. Okay? This is the place where the patient has been completed and ready for implant placement. There's a graft healing with a membrane. The lower incisors have been intruded, and the laterals have been uprighted and out of the way. Okay? So you can actually scan the patient without a guide. Okay? Certainly the technology is there. You have to know whether you've got valuable information or not. Okay? So what we traditionally do is we fabricate a radiographic guide with 3 pins that are related in the software to where you are in space, and we like to put radiopaque teeth in the radiographic guide. So you have some reference to where the final position of your teeth are going to be relative to just placing an implant in the bone, and then say, can I fix it? Okay? There's a degree of discrepancy from the angle of the proposed restoration to where you put the implant where we can't cope with an angulation change, and it's about at 23 to 25 degrees. So you need to stay near the restorative position because that's where we want the final restoration. You make the implant fit underneath that. So this was our plan. So we can use the co-diagnostics to position any implant system and where the sleeves go above the top of the proposed implant. And then we can do this surgery flaplessly. We're going to place 2 3.3 millimeter titanium zirconia alloy implants. So a 3.3 alloy of titanium and zirconia has 50% more mechanical property increases. In other words, a 3.3 is as strong as a 4.1. The advantage is that we can use a smaller implant and we're going to have more bone around it and more soft tissue to condition. So we're using a lot of those in central incisor, certainly in laterals and canines and first premolars. So actually that surface that's on the implant is actually then a 4th generation surface. It actually heals better than the previous one. Okay? So as Dr. Gallucci pointed out and Jay pointed out, the only drill difference in our bone level implant to the tissue level is that profile drill. We like to place the implants by hand so we can measure the resistance to insertion so we have some idea about the density and how stable your primary stability is, and then where you can load the implant or provisionalize it the same day, because these are going to be provisionalized the same day that they go in. So typically, as you saw, the guide allows the drill to bottom out on the top of the sleeve. Temporaries were placed, and then an additional soft tissue graft. At 12 weeks, it looks like this. And then at this point, what if you could actually scan that position? Okay, what if during the healing period you could scan the implant position and have an emergence profile provisional ready for the time the surgeon allowed you to load the implants? Okay, what if you scanned at the time of surgery instead of putting a bunch of polyvinyl in the patient's mouth? Okay, what if becomes a very good question, because all these technologies, as you look at them, say, how could that benefit me and my patients? Not just what they tell you at the booth. And I would tell you this, you have the great opportunity to walk next door and look at most of these technologies, and I would tell you, don't buy anything right now. Figure out what it'll do for you. All of them work. They work a little differently, okay? So typically, this gets sent to my lab, which is me, okay? I've designed abutments. I have the scan of the temporary as well, superimposed over it, all zirconia abutments. And then these are Emax lithium disilicate crowns. The abutments are placed, torqued to 35, and you've got a final restoration of the patient. Okay? I can do all that with the stuff I did 20 years ago, and it'll work out fine. I believe that it's a little better, particularly just the scanning with scan bodies and getting it to the lab and not having to take an impression. Okay? So it all works out very well. Now, the next thing we're going to do is talk about digital impressions. Now, my feeling is that my entry to technology, like for instance, Jay and I both like expensive sports cars. I have a German one that I can't change the radio station because I don't understand the technology of the German computer that's in there. Luckily, the radio's on my favorite station. Okay? Now, this is what I envision. So for the last 5 years, I haven't taken an impression of a tooth or an implant. It's all been by digital scan. Now, today, any of the systems that I point out to you, you should have the option to say, this is a digital impression. Do I want to then design and mill something out in my office, or do I want to send it to my lab and have them do it? They design and send it to a centralized milling facility. So in other words, it becomes like a DICOM file. It's an STL file that's interchangeable and accepted by anybody for whatever they want to do with it. It's an impression. Okay? So, for instance, they didn't tell me that I could cut 14 preps and take a scan and it would work. I didn't know any better, but that's the first one I did. So I have a cast that's perfect without a bubble, without a blurb, or without a fold in the impression material. Okay? And I'll tell you something else, is I use retraction cord about 10% of the time. Makes me, when I go back and place 2 cords, that's a lot of work. Okay, what's the predictability when you do that of having recession where you have a thin gingiva? Okay, so let's talk about what impressions are. Essentially, we've got a negative of the clinical situation that you can then pour dental stone in and have a positive and a replica of what's in the mouth. Okay, I'm going to bring up with you, how accurate is that? Okay? Are you going to pour your own impression? Are you going to trim your own dies? Okay? Good question. Okay? And let's say an impression of an implant position. So you have something that, like an impression coping, or something that you affix to the implant, that then, when you take your impression, it copies the surrounding structures, hard and soft tissue. It copies the implant position and the timing of the connection. Okay? So you've got a way to transfer that information to the laboratory. Okay? Now, for years we've done impressions. Now, there may be a few of you that are as old as me, but how many of you took modeling compound impressions for your dies? And then you took an alginate for your working cast. How many of you know what dental compound or modeling plastic is? Okay, okay, good. Well, we've come up with better stuff, because we used to take impressions with plaster and chiseled them apart and stuck them back together. Then you poured stone in them. Okay, then we used hydrocolloid till implants came along and we couldn't capture impression copings because this was too fragile. So we went to various elastomeric materials, okay, which was certainly an improvement, because when I graduated from compound, I went to polysulfides. And how long did it take for Permalastic to set? 10 minutes. If you had to take another impression, you had to put your cord back in, take another 10 minutes. Smelled and tastes like a Michelin tire. Okay? So we've gotten better. Okay? So today we're with the addition silicones or polyethers. Do you know the year before I bought my iTero, I used $14,000 worth of polyvinyl? Actually about 20, because a lot of the hands-ons I do, I get extra stuff sent and I take it home. So about $20,000 a year, okay? And so now the common thing is vinyl polysiloxane, okay? And all these things have different densities, setting times, and it's very good. So if I used Aquasil Rigid and it sets in 3 minutes, can I do as well with a digital scan in a quadrant? Like if I'm doing number 29 and 30, either implants or a preparation, it takes 3 minutes. So it's the same. And I didn't do cord, and I didn't pour an impression. I transmitted a file digitally. Okay? So you should be able to answer that question that Jay posed. Is this going to enable me to treat a patient better, and is it going to be financially a burden or not? Okay, all this stuff is expensive, and the worst thing you can do, like when I bought the iTero, my wife said, you know, you got to quit borrowing money. You're not getting any younger. I said, do you want me to die now? And it's like, we buy so much stuff because we're gadget people, right? And then we use it a couple times. That's not what I expected, and it's in the closet. Go to eBay. You can buy any of this stuff that people just didn't think it was that valuable to them, and they spend a lot of money. So I say, research it and decide, does that fit into my life or not? Okay, and I tell you, there are bumps along the way to getting there. Not that I haven't had problems, but I'll tell you, my life has changed, and I would not go back to what I did before. In fact, I'd fight to the death for you to take this impression machine. I'd give you the other technologies, because I say this is the most valuable part of the puzzle. So a digital scan records essentially the X, Y, and Z axis of tooth position or implant scan body and the surrounding hard and soft tissues. And so you're recording it in the form of a STL file, which is standard tessellation language. Just Google it. You don't have to go to the library anymore. You can Wikipedia just about anything, you know, and it'll look like you did a whole lot of research. Okay? So a tooth on the screen and a scan body. Okay? Now, I asked my brother-in-law, who's a systems engineer from the Naval Academy, flew every plane that we had in our arsenal, and he's now in the F-22 Lockheed Martin program, the F-22 and F-35, okay? So you have digital is zeros and ones if you start with the binary code. And the zeros either on or off, the ones either on or off, and you do 1,484 derivations of that, and that's the color pink. So you're not ever going to really understand this. But all the technologies come with training, and all you need to know is how to use them. Now, it's still difficult for me to say, you know, we really need to be able to scan the scan body, scan the temporary, and scan the soft tissue. Take 3 pictures. You can do that in the lab scanner. You can't do it with any of the ones that I know in the mouth. Okay? So how difficult is it for you to do all those? Probably not that difficult, but the manufacturers haven't figured out that it's important yet. To me, it is. So we're stuck with arbitrary, which with a lot of experience, we've learned how to handle that. Main thing is I like to stay around somebody young. They understand all this. So right now, the person that's fixing to take over is my office manager, is my IT person. I hired her when she was 16 and she was working at PetSmart. And I hired her to bag rooms and sterilize instruments. And she understands all this stuff. I don't worry about understanding. I just go get Melissa. Say, Melissa, this isn't working. Come help me. So I stay around somebody young. Okay? My grandson understands this stuff. Now, all this technology didn't start with dentistry. It started with our smartphone that everybody has. Have any of you driven to work and realize you don't have your phone and you turn around and go back? Okay, there's more power in one of those that was in our space program when we first went to the moon. You know, they were still using slide rules. And some of us don't even know what a slide rule is. One of my assistants comes through the lab and there was a 35 millimeter slide. And she picked it up and said, "What is that?" Really? Don't know. Okay, so all this technology started in the military and the space program. So when you look at what filters down to us, pretty incredible. So you can take the F-22, and that is going straight up. Okay, it can fly at 60,000 feet, dogfight at 50,000 feet, track 100 targets at a time. It can shoot down 12 F-16s before they even knew the plane was in the area. That's the truth, okay? And essentially, it's an electronic stick. There's no direct connection with a cable to any of those control surfaces. It's scary to have a Porsche that has an electronic steering wheel. It doesn't really touch the wheels, okay? Okay? But that's where we are today. And actually, how good we are today, do you think we're as good as we're ever going to be? No. 5 years from now, things are going to be different. I used to do things in 5-year increments. Now it's in 6-month increments. Okay? So, this is the workflow of what we see. We prep a tooth. We do some sort of tissue management. It could be laser, it could be 1 cord, 2 cords, it could be some styptic agent. Okay? Okay? Then we've got an impression. Now, what are you going to do with that? I used to pour all my own impressions. Well, I probably would now, and then I go up to the office on Saturday and spend 6 to 8 hours pouring all the impressions, separating them, trimming them, pendexing them, cutting out the dies, mounting the models, writing them prescriptions. Okay? What happens if a courier service in Dallas comes and picks that up in July, throws it in the trunk of their car, and continues on their rounds picking up impressions? I've climbed in the trunk of a car in Dallas in July. It's 160 degrees. How stable is polyvinyl at 160 degrees? How about if you throw it in the hold of an airplane and send it to Seattle? My point is digital is not subject to temperature change. So we've used a courier, a FedEx, and we've created a physical model, and we've created marvelous crowns and a final result, okay? Nothing to say that the first 39 years of me practicing dentistry was bad. It was just different than what I'm doing now, okay? With implants, we'd put an impression coping in. We'd make our impression. Okay, how many of you had trouble with polyvinyl or polyether with people with long, crooked teeth with recession and the gaps between them, or bridges that have, how many have locked a polyvinyl impression under a tori? Not a good thing. Okay. So, but we've been able to prepare a model, and then we make some sort of a prosthetic device, and we have a final result. Okay? Now, with prepared teeth, I can scan, and then we can send that file to our lab. Actually, it goes to Tel Aviv. It gets cleaned up. It ends up in our lab. They view it and see where the margins are marked. So that looks like Frank's preparation. Okay? And we can come up with a physical model 3 days later, or stay in the virtual world. You can do it either way. And then final restorations are fabricated with whatever material. It could be CAD/CAM or conventional lab work, and then a final result. Okay? So in the digital workflow on implants, today this is what I do. Healing abutment comes out. I may use my CO2 laser to uncover it, because a lot of times the healing abutment does not come to the surface. We laser away the soft tissue, place a scan body, and then this is what shows up on the screen, and we pick which lab we're going to send it to. We pick the connection that it happens to be, what implant system it happens to be, and then it's emailed by an STL file to the lab that produces a CAD/CAM abutment. Okay? So an abutment, zirconia coping in feldspathic porcelain, or pressed Emax over the coping. Okay? In a final restoration. So this is the problem with the analog world, and we've dealt with it. For instance, the discrepancies are when you change states from liquid to solid, not changing from Oklahoma to Texas, which is what I did. Okay? A state change, liquid to solid, there's distortion. So when we deal with impressions, model preparation, waxing, investing, and casting, okay, my theory was that I could scan more accurately than my analog impression, and I could end up with an accurate cast to do a screw-retained frame, okay? I've gotten there. It took me 5 years to get to the point that I tried to do it in the first place, okay? So our problems have been single units are okay, multiple units on teeth are fine, and implants. Splinted units start to be a problem, and particularly we can get straight lines to draw or to be passive, but restorations on a curve are a problem, right? They don't fit all the time, okay? And then the next thing is when I go up there on Saturday and pour an impression, like I did 3 months ago, I said, why did I do that? Then you hurt yourself. And I looked down when I separated the impression, I said, that can't be good. Okay? So I just don't do that anymore. Okay? So digital impressions, simplify it. It's some type of a file, and it's probably an STL file or will be. Okay? Some of them are encoded such that I can't accept one from somebody else, or I can't send it any place I want to. So there will be a common language. Okay? So your lab doesn't want to buy every one of the systems. It's just prohibitively expensive. So essentially what we're doing with any of the systems is we're shining an energy source on a physical object, our preparation or scan body. The visible white light, it's blue light, laser, infrared, LED, or X-ray. And we view the reflected energy, okay? And we capture that reflected energy in a camera, okay? So, and this is a way to compute the X, Y, and Z axis of a three-dimensional object and make it digital, virtual, okay? And essentially, this is what we see. So David Grattan in Iowa gave me this picture, and I'm going to show some additional of his stuff. And essentially, when we take this camera system and we shine it on whatever's in the mouth, it copies whatever it sees. Now, I Googled STL file, and essentially, we've got a series of triangles, and the more there are, the better your resolution, and the triangles have common sides, okay? And then that's your X, Y, and Z axis. Or, as I said, with the ones and the zeros. You don't have to understand that. Somebody does. Okay? So I can scan the mouth. This is a view of what the iTero is, which is a parallel confocal laser. Okay, if you Google that, it was invented in 1957, and apparently K-Dent had the license for it in dentistry. Okay? It's more like a laboratory microscope, which if I go over to the science building at Baylor, we use a parallel confocal microscope to look at our specimens. Okay? And then this is scanning that physical object as the laser passes over it, and it becomes an object on the screen. Okay? So the current technologies are these. Certainly CEREC has been around over 25 years. It's gone through about its third generation. E4D is the same thing out of a company in Richardson, Texas, Dallas. Okay? Those are two systems that you can do anything you'd like. At least CEREC has their own scan bodies. You can scan an implant position, and then mill out an Emax blank that you glue to their metal substructure, which isn't proprietary of the implant that you're using. Okay? iTero, 3M True Definition, the 3-shape Trios, the Carestream 3500, which is an LED light, and then Glidewell has theirs, which is a wand that has a 42 millimeter footprint. So you can scan kind of a quadrant with that. Okay? Now, I've used this one. I've got the 3-shape, and I've got the iTero. I would just say they all work for something, and they're all pretty much as accurate as, say, a polyvinyl. This one, essentially your scan is something like 0 to 10 microns, and if you send it to the Straumann Cares or Dental Wings, you can mill out something that's 2 microns from whatever your scan was. So it's very accurate. Okay? So a tooth looks like that, and a scan body looks like that. You learn to view the scan, is this a good impression or not? Okay? So in-office systems would be like the CEREC Omnicam today, or the E4D, or the Glidewell Glidewell, yes, and Carestream, okay? So those you have the flexibility of going ahead and designing a restoration in your office or an assistant designing it. If you know some dentistry, it's helpful, okay? Really, okay? You just assume people know dental anatomy. Now, all of us do, okay? Do you have an assistant that can do it as well as you? Some of us can say yes. Some of us would admit maybe they do it better than I do, okay? So it would happen something like this. You do something to the teeth, and then it shows up on the screen. You have a library of occlusal forms that you can modify, okay? And then generally what you mill out is a lithium disilicate or Emax blank in its blue phase. You stain and glaze, and then you've got a final restoration. So you've done that without a model. You can do the same thing in the Straumann Cares or Dental Wings system, okay? The Cerac Omnicam, this came out a year or so ago, and with the Cerac, you don't have to use powder with the Omnicam, okay? Then we have the True Definition, probably one of the smaller cameras. I'll just tell you that there's a disadvantage to having a real small wand because it doesn't retract the tongue and the cheek. Also, a lot of the systems, you can't just rest it on the teeth. With the iTero, you can rest it on the teeth, you can roll it left, right, and it holds the cheek and the tongue out of the way, and moisture control isn't an issue either, okay? So, essentially, this is what the True Def looks like. These are David Grattan's pictures. He's probably done more with this than anybody I know, and it does work, okay? And you do have to powder. Okay, so that's a disadvantage. If any, and you know, there are plenty of Cerac users here, and that's not a disadvantage for you, but it is for me for subgingival margins. But essentially, all the companies have some relationship with a design CAD/CAM system, and they have a relationship with some of the implant companies. And I'm going to kind of share you the latest of what that is. Trios is the new version for 3Shape. 3Shape has been around in the laboratory industry, maybe one of the biggest ones with CAD/CAM software. They added an intraoral camera a little bit over a year ago. I have this system. This is Charlie Vincent that worked for me for ages, then worked for E4D for 6 years. And we're scanning an arch. You essentially have this as like a video scan, video stream, and you're essentially going around till you filled all the picture. You point this wand at it, and it takes a picture of what it sees, okay? And so these are some of those 3Shape models. So this is what you see, okay? And essentially, these were the models. They're printed. I'm not a big fan of the printed model. I think the milled models, the iTero ones, are much better. This is the final crown. This is another situation. Scan the upper second molar, design, and then final restoration. Now, this is where I spent most of my time, and essentially this is what you have. You have an intraoral camera that gives you what you're seeing, and then you press the foot pedal and you get 0.3 of a second of laser energy that's 150 megabytes of information going back into the processor, okay? So that's essentially what we're doing, okay? That's what it looks like on the screen. Anything that's blue that's left is lack of information. So if you have a place that's blue on the scan, if it's not a thing of importance, that's not something that you have to go back and add another scan. Essentially, your scans look like this. This is where they come back from Tel Aviv, where they've marked the margins. Those are auto-marked. You can look at them. Sometimes they make a mistake. If you cut a nice preparation, usually the margin gets recorded properly. If you're all over the map, digital doesn't work real well. You need to have nice preparations and marginations. So the models look kind of like that. Final products look like that. Okay? So if we scan, create a model that looks like this, essentially I can't do gypsum products that well. Okay? And you can do 14 teeth. And it all works. It's all good, as I say. Okay? It's better than what I did before. So, you have a scan, A model that comes 3 days later, you've already got it in your CAD/CAM system. You design a frame, and you put porcelain on it, and you fit it on your model, put it in the patient's mouth. Now, let's say we're going to do 20 crowns on a patient that you see 122 times with very fragile gingiva, not much of a sulcus at all. We're not going to embed our margins subgingivally because then the tissue runs away from it. Okay? So our 122 times, made 6 sets of attempts, had it in the lab 3 times before I finally finished. These are my scans. How many of you can do 14 that look that good and not have a bubble? Or you get all the way around here and there's a fold. Just doesn't happen with digital. Okay? And the models are just pristine. Okay? And then final restorations, a combination of pressed and zirconia ceramics. Okay? You can take natural teeth in a patient that doesn't go submit to grafting and long treatment times and implants and the expense, and you can do CAD/CAM design, fabrication, and finalization. Let's say, what if you could scan at the time you placed multiple implants? Like, what if you could do that? Could you use that? Or sometime during the healing period? Okay, multiple scan bodies. I didn't know that you had to have them all the same, but there's a learning curve. Okay, but we do 8 CAD/CAM designed abutments, final restoration. Let's say we had this patient and we decided we're going to place an immediate temporary. Well, actually, we decided that probably wasn't a good idea, even if there was plenty of bone. But how about if we scan it at the same time, send it, maybe have a provisional that's made in 3 days? Okay, certainly you could design abutments and get them back. You have to arrange that. That's not the normal workflow. Okay, or you can do it at the time that you start the restorative procedure. Design 6 abutments in about 29 minutes that are all parallel. Now, you're going to be having your technician do it, but you could actually buy the software yourself and design your own abutments. If you do a whole lot of prosthetics and custom abutments, it would be well worth your while. So the definitive abutments are placed and a final restoration. Now, one last case, and then we're going to talk about some what-ifs. So a lady comes in, and she's got this nasty little disease here, and the tooth's going to go away. Luckily, it's not on the facial, okay? And we placed an implant after we'd done some orthodontics, and we scanned it, and we created a zirconia abutment and a final crown, okay? So all that's become easier because the patient comes in, they get a scan, I do a temporary, I shape the tissue, have the patient back in 30 days. I'm able to see if the tissue stayed where I thought, try in my custom abutment, make sure my margins were in the right place before I fabricate the final crown. Okay, some plan. Now, this started about September 1st. Atlantis will send you a scan body for your implant, generally the one you use, and then it's specific for any implant system. Then you scan the patient, probably with 3-shape, iTero, maybe True Definition, I'm not sure, but you'll send the scan to Atlantis and they'll make you a custom abutment. Okay? Let's say this is the new one, Core 3D. Have any of you heard of this? Okay, for instance, they make this scan body for 18 different implant systems and 89 different connections. Okay, that's a game changer. Now, the problem is you got to send the image to somebody that can accept it. Now, there is a center in Las Vegas that can accept them all. And then I called them. I said, well, what will I get from you? Because I really don't want you to make my crown. Okay, I like the people that make my crowns. Okay, so the trick to some of this technology, they'll stick it in your office, but you want to send them all your lab work. And you may not like what it looks like. Okay, so I want a printed model back with an analog in it. Okay, that's the first step. Next would be a model and an abutment. Okay, go a little bit further, or they'll do the whole thing, model, abutment, and the crown. Really, I don't like going there. Okay, now, what if, with any of these technologies, what if it's cost effective? Okay, what if it's accurate, at least as accurate? I'm telling you, with the iTero with teeth for sure, it's more accurate than what I did before. My insertion times and adjustment times are minimal. Okay? What if it increases your efficiency? What if? What if? What if it improves your workflow? And what if it improves transportability? You don't use FedEx or a courier service. It goes over the internet. Okay. What if it's better? Are you warming up to this a little bit? Because I'm not trying to sell it. I'm just trying to investigate and find out. So if a lot of these things are true, what are you going to do? Don't hide from the fact that things are going to be different in our world, right? Okay, you're doing things differently than 5 years ago. We're certainly doing things differently than we did when we graduated from dental school. I'm just saying, evaluate it. I always thought technology was a shortcut for people that were lazy and couldn't use their hands. I'm certainly not lazy, and I'm pretty good with my hands. But this is added to what I can do, really. Now, I'll put this lecture up on my website somehow. Actually, I'll have Melissa do it because she understands it. If I just gave you my email and said, send me an email if you want this, and I had to put it in a Dropbox for each of you, it's kind of inefficient. Okay, so check my website. Give me about a week, and it'll be under lecture materials. And it'll say the AAID meeting, and it'll be my lecture. 6 images per page, the whole thing. You can have anything I have, and certainly if you have a question, call me, because if you have something that doesn't work right, it's probably happened to me a whole lot more than you. Okay? And I've figured out some of the things to avoid the problems. So thank you so much for your kind attention, and hopefully you just see that there's something out there, if nothing else. Okay? Thank you. Thank you.